Started, and thanks to Bogdan here to introduce our two speakers today, which are Rebecca Germain and Liz Way. A little bit about Rebecca. She is an enrolled member of the Monterey Ojibwe Nation in Wisconsin and lives on the reservation. She received her PhD from the University of Minnesota Twin Cities from the College of Pharmacy. Her research interests focus on improving health disparities and social determinants of health for tribal nations, particularly in the Midwest states of Minnesota, Michigan, and Wisconsin. She's utilized a codified model and cultural specific approach to health model. St. Germain seeks standardized approaches to data within small population size statistical models and broadening our understanding of the meaningful use of native data through unique tribal characteristics. A couple of Dr. St. Germain's prior projects include illustrating the impact of an 8 priority community identifier, understand factors that contribute to homelessness, COVID-19, mental health, and substance use addiction at the community level. She's worked with a number of tribes as health outcomes, researcher, data analysis, policies and grants writer, administrative officer, and public health educator. Currently, she is working in Minneapolis at the Great Lakes Intertribal Epidemiology Center as an evaluator and interim director, the IHS Epidemiology Cooperative Grant and the Tribal Epidemiology Center Infrastructure Grant Program. I'll do a little bit about that too. He is the executive director with an MBA and an MLT. His background includes a degree in medical lab technology and a bachelor's in applied leadership and an MBA in management. He's a member of the Wisconsin Ho-Chunk Nation and brings a deep personal commitment to serving Indian country, but also a rich history of engagement with the Great Lakes Intertribal Epidemiology Center, GLITEC. And he currently serves as the director, as I mentioned earlier, of the Great Lakes Intertribal Epidemiology Center, director for good in the country, and the executive director of the Great Lakes Area. That's going. That's amazing.
He's actually coming over from the Indian Health Board, which is just a little bit off of Franklin Avenue, if you're familiar with that. I'd like to welcome you today to the School of Public Health. This is a glorious day. And while it's raining, we have just been reminded. When I was driving here today, I had to remind myself, rain is here for a reason. It's meant to wash away all the things that affected. But, you know, friends and faculty, there's many times we tend to put things into boxes, put things into paradoxes. Well, for us today, we're going to look at what the Great Lakes Epidemiology Center provides. We're right here on the 3rd floor. And so I'd like to introduce Will Funmaker and that matter of titles. So,
I apologize. I was kind of looking at that flyer and I thought, okay, this says 11 Central. Central? So I was thinking 11 o'clock. And then I'm like, oh, this says 10. And then there's a line like this, and then 11 Central. So then I was thinking, okay, 10 o'clock. So I realized that about 20 minutes ago, and I was talking to one of the other program directors. So I apologize for the lateness. I try to make sure I'm always in time. Just a little bit about me again. My name is Will Funmaker. I'm a member of the Ho-Chunk Nation, grew up around the Wisconsin Dells area. I do have a little bit of ties here. I was actually born over in St. Paul's. It's in Hennepin County that was there. So they told me to live here for a year and we moved over to our housing area there over in the Dells. So I live in Indian housing because our tribe doesn't necessarily have a reservation. So lots of different housing units and things. So that was my rough and tumble background there. Again, I from there went to the U.S. military, worked as a hospital corpsman. After that, went through school, different things of that sort, and started working. My background was in the medical lab, and then started overseeing FQHCs, Federal Qualified Health Centers. So I was overseeing multiple ones of those, and then more school, and here we are overseeing the epidemiology departments. And I've been here with GLITEC or GLITEC for about 3 years, in this current role for about 1.5 years or so. And just working with some great people, working with Dr. St. Germain, the gentleman in the back, Leopoldo, Anthony, and Schaefer, and just being able to see a lot of the great work that we've been working on within the organization, the region, and working with the great people here at the University of Minnesota. And just looking forward to having the partnership continue thereafter. So just a little bit on the personal side, I have a little Westie dog, and I do live in Green Bay, so I was up late last night. My sleep time long. And it's been a long morning, so trying to just move on. That's just a little bit. Thank you, guys.
Thank you very much, Will. I appreciate it. And I gotta tell you, this man travels the nation, particularly the Minnesota, Michigan, and Wisconsin, hitting all 34 tribes, 4 urban areas, 4 Indian community areas, Chicago, Milwaukee, India. I mean, it doesn't stop. He doesn't stop. And I'm so grateful. How do you hire people like that? You have a weekday and yet come back to work every day. This man wakes up at 3:30 in the morning to do this work. So talking about a role model. We're talking about social determinants of health, people within communities. You know, when Indian people come up to us and say, how do you do this? How do you get a job like that? I want to do it. You know, and I'm like, whoa, you know what? So you know what this is going to look like. You know, we've got our young, I said young, we have our researchers in the back. You know, and I tell them, you know, 10 years from now, maybe even sooner, take a look at the faculty, take a look at the administration, take a look at the people who are here every single day. This is what health is about. It's important. So spend a few moments with us as we go through these slides. And if you have any questions, administrative, federal, national, laws to that effect, Will Funmaker is available as well as myself. So thank you. So the first area, and I have to say this session is being recorded. So Jeff is downstairs doing his magic here. So tribal data sovereignty, a lot of questions we get involve tribal use of data. Community members, tribal leaders, outside organizations, agencies, NIH, CDC, SAMHSA, data-driven, hospitals, local agencies, county. So how do we use tribal data within the epicenter, and how is it accessible? Further to disclose. So the epicenters, they cover 12 different regions. They were started in 1996. They were affirmed and authorized, permanently authorized in 2010. And this is at the same time that President Obama came into office. And there was a push to put Indian health with epidemiology as a focus, as a mission to improve the health of all Native Americans and thereby improving the health of the community. So it wasn't just about the Indians, it was the community, and that's an important key concept. So of course, up in the northern region, we are called the Great Lakes Intertribal Epidemiology Center, or a TEC. Again, 3-state region, many tribes, 34 tribes, not just one community. So if we have students here, it's really interesting when you get one project, maybe from your professor, or you're working on a dissertation thesis. If you work for an organization like the Epicenter, you may be tasked with looking at 34 different areas of project emphasis. That's why the faculty are so important as we disseminate this education and this information that come through the portal.
And if I may just.
Yes.
Intervene as well, just in discussion, we can go back. And I was just up in White Earth up there, and oftentimes with the tribes, it's such an interesting work because there's so many different opportunities, grant opportunities that they have, needs that they have with their data and working within their public health realm, if they have a public health persons that are capable. And I believe White Earth, they are, which they work with IHS. They're one of the few that are what we call Title I versus Title V. Title I being IHS still runs their medical clinic. Title V being the money comes to the tribes, and the tribes run their own health clinic. So White Earth is one of the few that still has that partnership with them, and that's why I've been working with them. But they have multiple departments that work within their community there that we're trying to maybe offer that assistance with. So maybe they have the again their housing area, they have their clinical area, and they're not necessarily always talking, especially when there's kind of this division with Indian Health Service or IHS and the internal aspect of their work, the tribal White Earth Nation. And so that can be some of the challenges that we have. And again, every tribe within that region of the 34 federally recognized tribes has very different capacities. And again, I believe that there's 6 tribes within the nation outside of, there's only 3 within the state of Wisconsin that have public health accreditation. So they have a little bit more capacity to be able to deal with some of those needs in public health. But even then, we still offer a lot of assistance in working with their reaccreditation, how to get the processing, assisting other tribes in their public health accreditation as well. And that's some of the efforts that we're looking to, because again, different tribes have different capacities. They may not have the epidemiologists, the public health persons. They might have a community nurse that's doing 8 different things within them. And that's where we're trying to bridge that gap to be able to offer this assistance of the researchers, of Dr. St. Germain, me maybe in some capacity, to be able to work across them. And that's where I'm gone a lot of times, going over to White Earth, going over to Detroit, to the American Indian Health and Family Services, or anywhere else, to be able to let them know what we can do to offer that assistance. There can be turnover. There can be persons that don't necessarily know. So I'm always out there trying to sing how we can offer that assistance. Because tribes are falling behind a lot of those. And they're doing their best. They're working within their limited funding. Sometimes they're limited personnel. And we're trying to bridge those gaps in so many different ways to offer that assistance. And they're doing great work with what they have. But I'm going out, I'm going here, and I'm going there, as kind of Dr. St. Germain was mentioning. But I enjoy the work. I love what I do. I do wake up early. I do like enjoying these things. So I do send out emails at 2 in the sometimes. You know, but I'm an early bird. I start crashing about 2 in the afternoon. So that's kind of my thing. So you guys ever had to meet with me? Morning to me. But being able to again see the great work and going across these different areas and understanding those gaps that are within the tribes and seeing the great work and making those linkages that we're, I believe, going to be talking about. It's exciting, and that's why it keeps me going with what I do and trying to offer those the opportunities for our staff and for the tech and being able to work with universities, because it's such a huge need. It can be slow going, plodding at times, stepping back, or moving forward very rapidly. just again, just a little bit of a small.
Will, can you tell them the agencies that we usually work with?
We work with a lot of different agencies, NIH, IHS, state, local, SAMHSA, USDA,
Yes.
Yeah.
Right.
all kind, EPA.
Yeah.
We work with NIOSH, I think was something.
OMH.
You know, all kinds of different agencies, because again, tribes can have some limited capacity as to what they're trying to do with their persons. And maybe we're able to offer that assistance with some of their work. Because again, if you think about some of these tribes that are way up here, even over in Lac de Flambeau, where our central office is. And, yeah, and where, you know, where I live, just mostly in the party, but there isn't housing. And that housing aspect is very difficult, the infrastructure. And so we think about how can we bring professionals that are master's levels, PhDs, medical doctors, let's say in their health clinic, how can we bring these persons in, offer them the housing, get them the things that they are accustomed to. And those are the challenges that we're still facing every day. And that's how, again, we're kind of offering that bridge of offering those professional assistants in their work as they're trying to get that infrastructure needed for those professionals. As these federal agencies, these state agencies aren't sure necessarily who to talk to, and we can be that middle person. The techs are those middle persons, offer that maybe that bridge that gap and to have those discussions and offer a voice to be able to, who do we reach out to? I reached out to this person, it bounced back. It's undeliverable. It's not unheard of. There can be turnover in politics, there can be turnover in the departments. And we're able to offer that bridge, we're able to work with them. We might know somebody that can talk to somebody else and maybe give us some of that information. So, because that's kind of that important thing of why am I gone? Because I need to understand who to talk to. Who is the resource? Who is the resource for us internally? Who is the resource we can make a connection for? The University of Minnesota wants to work with Leech Lake. Okay, who can I talk to? They reach out to Leech Lake. Why don't they talk to us if they want to? And then we can reach out to Leech Lake and offer that assistance if that's going to work in hopefully the give and take that works best for the tribe. Because it's always been what's going to work best for the tribe in these instances. So that's what we again offer that assistance with the federal, is again the local or even state level, working with the many different agencies that we.
Yes, thank you for that. This is so important because many times, does this make sense to you? When we're doing projects and we have to have those resource people, who do you find? Many times when I go back into academic arenas and they said, well, we tried to work with them, I had no response. Well, so-and-so. And I said, well, maybe we could have talked to someone else that we know personally, you know, because of these relationships that's being established.
Or even or even they're like, well, I talked to this person. Well, yeah, you have to go about it this way.
The protocols.
You know, and hopefully we understand that process a little bit more. And that was something that I was just meeting with, like I said, up in White Earth this last few days. Mayo wants to work with a lot of different things, and they have some great opportunities that they want to offer, whether it's in diabetes, some of their newer child behavior aspects. And it's great stuff, but they don't necessarily know how do you reach out. I'm like, I can't just go and do these things. Or, and there's intentions, but how do you go about that intention? Does this fit their needs? Even though you think it's going to be for their best benefit,
right.
does that fit the tribe's
And do they
needs?
understand what you just said?
And how do
Right.
you approach that tribe? Do you go to the health director? Do you go to the president chairman? Do you go to council? Do you bring it to somebody else to bring it in? And that's where we can offer those assistance and these things, because it's gonna take some time, it's gonna take some effort at times, but we know, a lot of times we'll have a good idea of how to approach this. Just kind of a little bit of FYI in some of the process.
Yeah, so it's crucial to understand the foundation. Many times we just kind of glaze right over a mission statement, for example, or really what is the impact of an epicenter. For some of you, this isn't a new topic. You've been here through and worked with GLITEC in the past, and others, this may be new, particularly. So this is a new day for health. You know, because of the national crisis that we just came through with the COVID and also with the opioid and also the SES and the social determinants of health, we've understood now, those of us who are out in the community, that we need to use this different approach. You know, talking, really listening to the voice of the people of the community. And what just happened maybe a couple years ago, talking about identity. How important is identity? You know, George Floyd, right? How much did that shake the foundation, you know, of this great city, but nationally, how did it affect us? So I'm going to go through a couple of these slides here because I do want to spend some time for questions. If you have projects, if you have, and any question is fine. Don't be feeling it's awkward or inappropriate, insensitive. This is what we do. So again, some of the technical areas that we do is survey development, analyses of any data that comes through, cultural assessments. And right now, there's a big push to get one Indigenous type evaluation tool, right? What to use to evaluate tribal nations. So I'm going to tell you, there is not just one, because remember, listening to the voice of the people determines your next, how those questions are constructed. So public health law and policy and tribal specific reports. If you could remember this one area, I'll get to the slide. You won't have to remember. So again, we work with urban organizations as well. Evaluation, grant writing, looking for grants. Sometimes we're in a situation where a tribe is desperate, especially what happened during COVID when we were under shutdown. What happened to the people who were homeless? What happened to the people who did not have medical care? Where do they go? I was in that situation, called home to my home reservation. Dr. St. Germain, you're a doctor, fix this, you know. And I'm like, oh my God, this is bigger than us. You know, we need a team, we need a different approach. Tribal council, we need funding. Nope, you can't ask us for funding. What do? I actually called the Great Lakes Intertribal Epicenter, and they gave us Saving Lives Project. They gave us our initial funding to open a shelter for homeless men. GAP resources. I gotta get off of this. All right. So building capacity. We build capacity, we build structure. We provide answers for sometimes things that don't seem to have an answer or an outcome. We work in various sensitive areas, from HIV, Hep C, fentanyl, testing strips, giving out Narcan, providing training in those areas. One important concept I'd like for you to consider today is data privilege. This is a new term that has not been codified, other than me just making things up. Data sovereignty, data governance, you know, ethics, cultural humility. But what we haven't taken a step back is, when we look at data, sometimes we're conflicted between what is the consumer right, what is the client right. Client right is more akin to HIPAA. This is my data, I'm in control, and you can't use it. And we have protections for that. Consumer right meaning, but I'm the health, HMO, I'm the pharmacy, I'm the insurance group. I have to know your information. So then where does the privilege come for you as an individual, whether you're native or not, having that privilege of data? Another concept we need to put into practice. The tech centers look at the story. It's not just one point in time. It's a story of how we came to be. So when they say it's very hard to use Native American data, how do you use it? It's all qualitative. Not necessarily. So if you look at it in terms of case study, that first picture in case study 1 is a wigwam. It's actually a Medewin Lodge wigwam. It was put on our backyard. Case 2, teaching our young people. We talk about food is nutrition, food is sovereignty, food is medicine. There was a major food nutrition conference in Shakopee last week. Hugely important. What is affected right now? PFAS is going to affect our consumption of something so natural as fish. And then, of course, generational studies. How many of you have heard intergenerational trauma, historical trauma? Lots of different names for it. We have also all different names in testing for things like this. How do we make good of our data? Data privilege again, a little rubric here. What we look at is her terms, and this is a new rubric. I kind of devised it. So the point when I say that is, if you have an idea of how something that can be effectual work within our community, say something, because we can't get that information out unless you talk about it and say something. This is how I'd really like to do something within a community. I don't know if I can do it, but here it is. And I know it's based on something. What it does, it brings us to a place where we can use it. As we know, technology is moving fastly beyond some of our capacity, data modernization. So Indigenous sovereignty, here it is. The right of an individual to own and have control of your data. Tribes are sovereign governments. So data sovereignty is a priority of the epicenter. Data governance, how do we use the data within those protocols of a tribe? GLITEC can help us with that. March 2022, tribal epidemiology centers were tasked with Congress basically asking us, get out there and find the data, use the data. So when we're asking for data, some of you researchers, what issues do you have when you're trying to look at data? Access. So we're denied many times. We don't have access. You need an IRB. You need to go through this and this quality measure, etc. Same with the text. However, they forgot for the epidemiology centers are already recognized in Public Health Authority in 45 CFR. We have a right to have all data. Public health, PHI. It does not have to be de-identified for us. That's why the GLITEC organization is very important for researchers that are doing research, because we can actually house that data within our auspices of our data security measures here. And we can be that middle person. So linkage.
And if I may,
Yes.
also just in that discussion about that access to data is something that I go out and I talk about with oftentimes, whether it's at the state level, and the local level as well, is again, often I find in what that GAO report was kind of just showing previously, was there's not a process in place. Usually if we come to, let's say we come to the University of Minnesota, we come to the state of Wisconsin, state of Michigan, they aren't necessarily unwilling to give us whatever the particular data may be that we fulfill what the tribe is asking for us. It's that they don't have a process in place on how to get that to us. So then you have to determine what's the process for the text, because then you have to kind of educate them about who the texts are. How do we decide that? How does that work within their areas? Can we utilize this particular information? Yes, we can. Yes, we have authority to get this, and yes, we're going to get this in a particular way as politely professionally as possible to fulfill what the tribe's needs are. But again, it's it's oftentimes trying to find that process. And that's what we're working on pretty diligently now. And we've been working as the techs all together. The director's been meeting to be able to put these processes into place, provide that education, again, having these discussions with everybody here, having the discussions on the University of Wisconsin campus, University of Michigan, who we are, what we do, and how we're trying to do that. And into the minds of students, faculty, and everybody else, so that maybe in 5 years when we come across again on tech, that maybe it puts a little trigger in your mind about how we work and who we are. So, like I said, it's oftentimes there's just not a process in place. And that's what we're trying to do, is have that process, have that internal process for those particular workplaces. And then getting that data and that information from the states, the federal persons, getting that into some useful format for the tribes to be able to meet their needs.
One point about it, many times tribes complain, well, you've done this policy without us. And we're going, no, we're here now. We're going to do a focus group. We're going to do a thing with you. Is that okay? And tribes are going, no, what they want to hear is, oh my God, I've got an idea. Can help your behavioral health department. I've got an idea to help social work or public health. You've got a whole contingent of public health nurses, but are they actually in the community? And that's where tribes will say, yes, come on over, meet with our divisions. You guys know how to do the data, you know how to make your spreadsheets, you know how to actualize. Do that, and then it's about us, if we are grant writers that can actually fund this. So that's the process they want to hear. Not come out sometimes and they go, oh, we have a policy that we're going to work with tribes. They want to literally be at the ground level. If you got an idea that you want a research project or do something, give out Narcan, go see elderly, things like that. That's what tribes want to say, let's develop it together. That's the collective voice. And that's where, when we do data analysis, and myself as an evaluator, and I have statisticians and analysts sitting in the back there, that's what we're looking for, to hear that. Did you actually visit with people? Doesn't have to be professionals, just people. What are they saying? So right now I left some information on the table there with GONA, Gathering of Native Americans. This literally is, some people call it appreciative inquiry. This is CVPR all over again. Only it's nomothetic theory. Nomothetic, all data is data. This isn't a new concept. Way back 1937. So again, a little bit of semantics here. What is most familiar to you on this slide? What do you see there? What are some words that you can resonate with? The most familiar words. What do we tell our students? We are going to do a survey, right? We're going to do a case study. Maybe we'll do some clinical experimentation. Many times we're not able to get past that point. And this was new to me when I was actually doing my dissertation as well, because I've never considered. I worked in policy, worked in theory, framework. How does it really happen? So in 2014, I actually found it. It's been published. So for tribes, where we exist, and it's actually up in policy and implementing policy compared to the rival theory, such as maybe health belief theory. Does that really work for us? Good time. But theory, we're changing those theories. That's why faculty, you guys are so important with this. PhD students, build off of your brainstorms or your thoughts. Change the process. Okay, so I just blazed through data modernization, large topic. Not going to get into it, but all right. And I'm trying to be respectful of time too, because I want to give you all chances to ask questions. So again, this is IHS strategic plan, the objectives. Objective of number 3 is to modernize the information. That is going to be sitting on the heads of people who actually go to universities and then also with community leaders, whether they be tribal government or like Indian Health Board, where administrator says we need to figure out a better way to link our data to patients. Their data is all over the place. They go from the tribal clinic to HCMC. Now they're over at Fairview. They're all over there. How do we get the same message together about this person's health? That actually is a definition of data linkage for us. And it's got to be driven by technology. Otherwise, it's just a lot of work, trying to do this by hand. Where do we get the codes? IHS. Standard code book. If you're working on social determinants of health, get the code. Z59.0 is actually the code. But CDC availability, NIPERS. So they're up to 914 new data sets with the advent of data technology coming in. And these are great. I won't open up the links right now, but they are really informative. Well, maybe I can look at this one. Sure.
Outcomes, death, or morbidity that happen to tribal members on reservations versus when they're off reservation. Does CDC want to know all of that, or are they only seeing stuff that's reported by non-tribal entities?
So there are data statistics on death captured by the IHS if they are living on the reservation, because we have patient referral systems, PRC, that actually will follow it over. So that's one area that's a good plus. We can follow it. If they go to a hospital and they call back to the clinic, I've just been admitted for something, then tribal health director, and it gets coded. We can follow that. Now, if they are living in the city and they still say they end up in the ER or they die, that data will be held by the state. So again, the epicenters are the only ones that can access those types of information. So if you have a project like that, how do we match? That's why the value of having long-term administration native, we have that internal knowledge of who's who belongs where, what tribe is.
And that's some of the challenges that we're running into again is how do you, if somebody dies, what is the process to be able to identify them as tribal? And what tribe are they? There isn't currently anything in place to designate them a death certificate. And so oftentimes they're miscategorized, they're not categorized at all. They look at it to get us immediate family, they don't have family or something of that sort. So we've been working on having a policy put into place to be able to work within the state. I believe there's an association. Colleges or something along those lines to have that identification put into place. So again, how do we identify these people and then count those numbers of these deaths that they have and everything? And that's something that's been very challenging, obviously, and something that we've been working on, but it's going to take some time. I'll see with that aspect, so we need years in the making. It's something that's we've been working on slowly for the last year or two. Even with this data, the data modernization efforts, like Dr. St. Germain's talking about, it's such a huge need. It's something that, like we're talking about, how do we identify our tribal members? Once they step off the reservation, 60–70% of tribal persons are in urban environments, and they're not being identified. How is the tribe able to identify their tribal members? And once their tribal member comes back to their reservation, their facilities, or wants to be seen, well, that doesn't necessarily follow them. And we've seen this in any sort of healthcare system. If we go from Wisconsin or Minnesota down to Florida, our medical records are just now starting to follow us to things. So this is even more difficult with tribes because not only are they working with some much more archaic systems with RPMS, which I can't remember what that stands for.
Resource Patient Management Monitoring System.
Yeah, but they are going to work with it, but they can some of the other larger systems But as many of you probably know, they don't necessarily still talk. So that's part of our effort, is being that middle person and being able to pull that information, be that repository and get that to the particular tribes if they're being seen somewhere else. So making those linkages, pulling that data from the state, getting that data, cleaning those sets up, and then making it a presentable form to the tribes so that they're able to have access to that in real time. So that's just a lot of kind of in a quick nutshell about some of those things with the modernization efforts. And again, kind of answering about this, the death certificates that, it's definitely a challenge that we're trying to face across the country that people are really dealing with.
Thank you for that. I don't know if in public health you actually cover coding. How do you get your data? Do we do anything curriculum wise? A little bit. Very important. As a healthcare administrator, as a health director, I walk in, first thing I do is drop those codes. Give me the server, give me everything. Because if we're there to look at the health of a community within the health clinic, I need access to all the codes. So overdose deaths, everybody's seen this, right? Do you actually know why that takes off in that direction straight up? Their physicians are saying through the CDC that it is due to fentanyl, xylazine, primarily fentanyl that is now mixed in weed and marijuana. So who's going to test for that? Again, same thing. This is Minnesota. Here is Native Americans in Wisconsin. You know what's important about this? Can you see in that little circle what it says? All of the pie shape, those are the numbers of people that said they didn't use the question on that survey. Because the people I talk to are saying, hey, I might have a problem, I really need help and I'm tired of this life. So where does this question come from? We gotta find out. It's homework. Interesting though, right? Interesting, but there's always a story behind it. Again, ideation. Linkage. Who do we link to? All the projects probably your students are working on right now can be linked to for a greater purpose. It actually is the CDC linkage plan. So all this is contained within the slide deck. You can peruse it on your own time here. Current programs we're working on: PFAS, lead, public health capacity building, whatever the tribes request, we help them with it. Good health and wellness, coronavirus, continuation of substance use disorders among tribal community. Policy templates, we get the attorneys involved. Initiatives, data modernization, zero suicide, testing, coding, staffing, expertise, policies. Those are important topics that are all involved in health, public health. It's not just chronic disease surveillance. For us in tribal health, it involves a whole facility. And the reason why I asked about coding, because this is what sustains clinics. If you realize within your research that it's not just maybe one issue that you're identifying, maybe there's 23 others that came up statistically. Maybe there's a whole nother thing that we need to look at. There's codes for this, or maybe we have to develop those new codes. We can bill for it. And then the public laws that support, and then recommendations. The blue box is actually how to get tribal approval if you want to do a research project. And of course, we can help with that. Questions? Thoughts?
If I may,
Go ahead.
just kind of thinking about again how when I talk with staff members and I talk about our partnership with the university or universities that we're on. And I always view it as a little bit of a missionary work. we're the missionaries, in a sense, for the tribes to the campus. In showing that knowledge, being that resource, being those persons that are able to speak for persons that aren't always able to on the universities. And being able to bridge those gaps, walk in those two worlds that we often do. Dr. St. Germain and I, again, we're tribal members. So there's an academic world that is there, and then there's that tribal world. And they often don't mix very much. They try, there's efforts, but how can there be those bridges? And that's what I view as so important in this partnership, and why I value us being here for our staff to be able to learn, but also speak for the tribes as best as we're able to. Again, some of us may be a little bit more than others, some of us have more background than others. But being able to talk with everybody here and share some of the work, because again, tribes have a lot of challenges, but there's a lot of successes that are going on. And it can be slow going at times. And like I said, it speeds up, it slows down, it steps back. But the universities, again, where a lot of things, a lot of great work is going on. And I know there's a lot of good intentions with a lot of things. And I appreciate that. And we can be a bit of that resource to be able to assist with the work that goes on, as long as it's benefiting tribes. And that's our main concern, in being able to reach out and be that resource for the tribes, and be the resource for everybody here as well in your work. And that's why we're just able to kind of talk about that. The big things that are being talked about across Indian country, the data modernization, opioids, the Minnesota tribes, I believe they're number one in the country.
They're number one.
Number two, maybe Wisconsin.
Yeah.
And the two of the three states that we have, that we work with in our region here. So those are two big efforts amongst plenty of other ones as well. So that's where, again, where a lot of the focus may be with tribes at this particular time, but that doesn't mean there's not other avenues or other areas for them in their need. And where it behoove you guys to talk with us if we're able to offer assistance in some of that work. Again, we try to provide that roadmap, provide that assistance one way and the other. And that's where, again, it's vital for us to be here, and vital for us to share these things with you, and for you to talk with us and ask us any questions. And just it's good to hear other people's perspectives. So just wanted to share that a little bit. Yeah,
Mind if I, this room is really loud, so
Yeah.
anybody's talking, should use the mic. Thank you so much. I am really glad that you put your address on the last slide, because I feel like a lot of people are not aware that GLITEC has a satellite office like right here. So I was wondering if you could just talk a little bit about like sort of what you're like, what the satellite office is doing here, how open you are to people from Epi reaching out to you, because I know you're really busy, and there's some other people in the room that I believe are based here too. So maybe you could like point them out so that we would just be more aware of each other.
So team, if you would like to, yeah, I can take that.
I'll keep it filled out.
All right, so you guys stand up in the back, tell them where you are.
I think geologist studied at Boston University. I'm based here in the Minneapolis office. And then I predominantly building requests from either the tribes or for our sister organizations, or like external groups that help addressing needs assessments, surveys, gathering data, submitting information.
Yeah, hi, I'm Anthony Johnson. I'm epidemiologist here in the Minneapolis office as well. Been here about a year, went to school here at the University of Sydney. Yeah, I do a lot of data work.
My name is Leopold, but you can call me Elvin. I'm a public health specialist. I've been here for 3 months. I moved here in June, to Minneapolis from Metro Detroit, Michigan. And staff made, finished undergrad at Florida State University. And so far, it's mostly on community and on surveys.
Thank you very much, but yes, I'm very proud of them, that's, Chambers, from Hawaii. So, Indigenous culture there is predominant. It's only here in America where we have. Or you want us to call you, things like that, and so if you go background, you think about your grandma, your grandpa's, say, history of who you are. Tables, all that data that comes in your opinion never turns us down. LJ, he was brand new, and it's like, LJ, we're going to maybe now, and there's something about it.
For our offices here, again, just how do we view it? Again, I view that as that missionary kind of work. And being able to, again, be that bridge for your work, your questions, to talk with our staff. I encourage them, our staff to talk with the university staff and vice versa. We are not just entities holding down office space here. We're here to collaborate. Because again, your guys' information is going to be real vital at the cutting edge of this work, of the research that we can think about. Again, we don't necessarily do the research aspect, but these things can be maybe bridged to the tribes and presented to them, and we can be those facilitators for you. Doesn't mean it's always going to be taken up. It just means we can help facilitate that in an appropriate way that for the work. So we have those offices here on the university campus, just right down the hall there. And I encourage you, go and poke your head in the cubicles. And I believe LJ usually has snacks over there too. So I try not to eat too many of them. But so we have the offices here on the 3rd floor with the gentleman and Dr. St. Germain, I believe.
Yeah. Yes, that'd be coming.
And then we have offices over in the Indian Health Board just down the street where I was at earlier. And we have a couple offices there because I believe you need to be in those tribal offices. We need to be seen and be a resource. Again, we're not just their EPIs, but again, it's important to be in those tribal office buildings while also thinking about that need for housing. Like Shaper, Anthony, LJ, we're looking for housing here. It's a little easier than the others, but at least you can find housing in some capacity. So that's where, again, we're trying to meet the needs for our staffing, put them in a bit more urban area, but also making sure we're keeping our focus on tribes. And then our offices down the University of Wisconsin and over in Ann Arbor as well, the University of Michigan. We're working on offices with the Ho-Chunk Nation over in Green Bay. I believe hopefully those will be in the next maybe in the next month or two. And then possibly with Saginaw, Chippewa, and Michigan. Again, meeting the tribes where they're at, being that face, being able to learn from the tribes, and then also being that resource. Because we have to be sure that we're able to meet the tribes. And sometimes we will hear that too. You guys are stuck up here on the campus offices. I've heard that. And we have to make sure that the tribes understand that we're not just staying here and being office enemies. We're community. We're community. We work with them. That's the fun and the interest. There's so many different opportunities in working with the things that we do. National opportunities, working with all these agencies, being able to work with the universities, and it can be exciting work for sure. It's never the same any day. And like I said, we can be busy, But I always encourage anybody to approach and find how we can offer that assistance. And we tell our staff that we should always be accommodating with them, while also prioritizing.
So we're almost at the top of the hour. Does anyone have a super quick question? It's 10:59.
Okay, so are we gonna use this information? A lot of times when we're looking at research projects, et cetera, we skip the impact. Not by, we're just over there, right down the middle. We will always make time for you. Not work.
Thank you so much. I really appreciate you guys being able to spend the time and you being able to spend some of your valuable Minneapolis time with us this morning. If I don't know if you have a few minutes to stay after. Is there a room in the room? 11:30. Okay, so if anyone has a few questions they didn't have a chance to ask, we can hang out here for a few more minutes. And otherwise, I'll see you all next week. Thank you. So much.
Thank
Thank you. Thank you so much.
Yeah, absolutely. Okay, so I was looking at the flyer and I was looking at 11, and 11 was like, is that 10 Easter? I was like, yeah.
Reading. I was saying, and then when I heard you were coming through the airport, I was like, I should have gotten an iPhone right there. But I know, but I just
So.
try.